I have the privilege of welcoming Dr. Anagha Heroor, and Dr. Anagha will talk to you on a situation where there is no posterior support, and you are you still have to salvage the position, and you have a backup lens. It could be a three-piece IOL, or it could be an iris claw. An iris claw is gaining a lot of popularity. It's easier to do it compared to a still fixated lens. So, and even Kiran here has a lot of experience with the iris claw lenses. So this would be a wonderful platform to discuss about these lenses. Anagha, over to you.
Thank you so much, Dr. Chaudhary, and very good afternoon to everyone here. At the outset, I would like to thank Dr. Sanjay Chaudhary sir for inviting me here for this talk. So basically, if you look at the history of the iris claw lenses, you had iris claw lenses which were in the anterior chamber also, but it was Brass and Nohan who modified this technique and they fixed it to the posterior surface of the iris. So the better advantage is that it can help preserve the corneal endothelial cells, and remember that the A constant is altered accordingly to 117. So when would you use a retro-fixated iris claw? First and foremost is there is no capsular support. Definitely if you have some kind of anterior capsular support, you would, there is no anterior capsular tear, you would first prefer to use a three-piece IOL. But in case there is an anterior capsular tear, there is a large PCR, or there is a total bag which has come off, obviously you have no choice. So in such conditions, retro-fixated iris claw works well. Now, secondary IOL is also a condition where there is a patient has come to you with aphakia and you want to put in, give him a correction with an IOL, so the secondary IOL, or the IOL that has been put in the eye has dislocated and you want to do an IOL exchange, so the entire capsular bag has fallen off and now you have to treat the patient. So what are the principles of treatment before we even go on to the surgery? Prior planning, you need to understand what the patient is, take a slit lamp photograph of the patient and plan how you're going to do every step. Before you even take up the patient for surgery, in case of a planned, either an IOL exchange or a planned in aphakia case, a peripheral retinal evaluation to rule out any kind of pre-existing retinal tear or hole, perfect biometry. So whenever you are doing any case, suppose you have a high risk case, suppose you have a very high subluxated cataract or a hard brown cataract, or a very small pupil, wherever you feel is a very high risk that you might need an iris claw, you do a proper biometry and see that the A constant is adjusted. So select the lens properly. If there is a planned case, then specular biomicroscopy to look for the corneal endothelial status and OCT macula in these cases. And as I said, in all high risk cases, you keep a standby three-piece IOL, claw instruments, diluted tricot, vitrectomy, everything ready, and counseling of the patients also. So coming to the surgical principles. Now, because this involves enclavation of the iris to the claws, definitely it can cause pain. So these patients prefer to do under peribulbar block. Another thing is how much incision would you do? I'll show you a lot of cases. So if you're making a sclerocorneal tunnel, it should be at least around 5.4 millimeters. Side port should be ideally at 0,180, that is 3 9 o'clock. And the more direct it is, it's better. If you make a very long tunnel, it's difficult to maneuver the side instrument and it can act as an oar. So it restricts the movement. Always check for the capsular support. We had a case where there were a lot of capsular remnants there. And then if you try to put in an iris claw, there is no place or it can get tilted. Look for proper iris support. If there is no iris support or if there are iris defects or atrophic areas, avoid those areas. Check for presence of vitreous. You have to see to it that there's complete vitrectomy done, anterior vitrectomy, posterior vitrectomy, as the case may be, and only then go in for the lens. Now, neither you should have a very small pupil nor a very large pupil. If the pupil has been dilated or if it's dilated because of a peribulbar block, then put in a little bit of pilocarpine, and normally it should be around 4 to 5 millimeters. If it's too small, then when you're maneuvering, it can cause a sphincter tear. Use the right OVDs to keep the chamber formed and avoid sphincter trauma while enclavating the haptics. Now, you have a lot of companies which will give you these iris claw lenses. They are all PMMA, either biconvex or convex concave, with an IOL diameter of around 7.25, 8, 8.5 or 9 millimeters. So how important to know, why why it is important to know what kind of lens you are using. So if you are using the older biconvex configuration, remember there is a chance of a pupillary block. So you'll need to do a PI. But the newer lenses are convex concave and with the concavity oriented superiorly, anteriorly. So here you need not do a PI. So that's why it's important to know which kind of lens you are using. This has a better safety profile. What contraindications are there? So obviously if there is an aniridia, there's no iris support at all, rubeosis iridis, lot of iridodonesis, active uveitis, obviously these are cases where you will not operate. So this is just a small animation to show. So here you have made 2 side ports at 0-180, main incision, check with diluted tricot, do a complete anterior vitrectomy, and then put in a little bit of pilocarpine, keep the pupillary diameter at 4 to 5 millimeters, use the lens, check the patency of the claw every time before you put it in the anterior chamber, rotate it horizontally first with the 2 Sinskey hooks, hold it with a tight and nice grasp, and then on both the sides you can then tuck the iris through the claw, enclave the iris, and you are done. So let's see a few cases. Now this was a patient where there is a dislocated cataract. So here first of all we are doing a 3-port posterior vitrectomy, managing with the phacofragmentome the cataract. Once this is done, then we will have a condition where there is a aphakia now. So now we are putting in viscoelastic. I've made a scleral tunnel, as you can see here. The pupil is nice and round, and now we are using a iris claw. So we are first checking for the patency on both the sides. Put it in the anterior chamber. See that the chamber is well formed. You can replenish it with visco. Rotate it to the sides where you have made the side ports. Grasp it well. Put in the left side. You are using the iris claw instrument to just tap on the iris so that you can enclave it. So you have to have it ready even before you bring the iris claw, the claw below the iris. So see in my right hand, that rod is ready. Then with the left hand, grasp it well, bring the claw towards where your instrument is, feel for the notch, and then just dip the iris. So you have done it, and then you can suture the main incision. This is another case where it was a old case of pseudo exfoliation, and you can see the entire lens capsular bag is moving and is subluxated, which will have to be removed completely. So again a scleral tunnel is made, and in order to facilitate bringing out the iris, bringing out the entire capsular bag with the lens, we are putting in viscoelastic and bringing it out very gently. The entire capsular bag with the lens comes out. Doing in a thorough vitrectomy, checking with diluted tricot. See that there are no vitreous strands. Again, taking in the iris claw, check for patency each time. There have been cases where it has not been checked, and then you are trying to push in the iris and then it doesn't. So then you are faced in a situation where it's enclaved on one side and not on the other. So this should not happen. That is why you have to check it outside. So then fill in the chamber with viscoelastic, grasp it well, and then with the rod on either side, you can just enclave the iris on each side. So where to enclave is also important. It's in the mid-peripheral area. If you are very close to the pupillary edge, then it can cause a ovalization of the pupil. So this was an interesting patient, a patient for trauma. There was not only subluxated cataract, but also you can see that there is an iridodialysis. So you have to treat both the iridodialysis as well as the subluxated cataract. So first we have made a scleral tunnel 1.5 millimeter away from the limbus in the area of the iridodialysis, and using a railroading technique with a bent 26 gauge needle and a 90 double-ended nylon straight needle, we are first treating the iridodialysis, suturing it, and then tying the suture so that the knots are buried in the tunnel so that it doesn't irritate the patient. So the pupil is nice and round here. Now the second challenge is removing the dislocated cataract. So we are making another tunnel temporally. because superiorly already there is a tunnel where you have sutured the iris, so that cannot be used. So now we are removing the dislocated lens, doing a vitrectomy here, and now you have to treat the patient with, you need to put in a lens. So this was a patient of trauma. So there was a traumatic mydriasis also. So we are trying to put in pilocar and see, pupil is not really very small, but it's enough adequate support to put in an iris claw. So again, on both the sides, we have managed to put in the iris claw. This is another case where, again, there was a dislocated IOL. So it's an old patient who came back to us. So here again, we have made a scleral tunnel, putting in a 3-port. And then you can see down how the IOL was dislocated. So first you need to bring that out, do an IOL exchange, remove the old lens. As you can see, this is the single piece Rayner type lens. If it was probably a 3-piece, then you could have probably made it as a glued IOL or a Yamane technique. So once this is done, constrict the pupil, put in viscoelastic, and then similarly as we have seen earlier, put in the iris claw lens. Rotate it, and then on each side you can just dip in and enclave the iris. This was another case where you can see how the IOL was dislocated, but you can see the haptic in the inferior area. It's best to do these 2 side ports first and then open up the main incision. Bringing out the dislocated IOL first through the scleral tunnel, and then you can put in the iris claw. So these are complicated cases where already there is a procedure of removing the dislocated cataract or the lens. So in such cases, this retrofixated iris claw is a very quick technique which will reduce your surgical time. If you plan a glued IOL or a Yamane, it will involve even more manipulation, maneuvers, and surgical time might increase, especially if you are a beginner. So this was a very interesting case, cataracta nigra, a very hard black cataract, and there was a lot of phacodonesis. So otherwise we would have planned an SICS for this patient. But see, we have used a very old technique which we were taught in our residency of cryo. So we're just opening up the incision using the cryo, but it's a very clean technique. There's no vitreous loss also. You can see how black the nucleus is, a very large one. So it would have been probably phaco or a SIC, because it was a very, there was phacodonesis, we planned to do this technique. And then putting in an iris claw. So I think for want of time, I'll shift to some struggle. So this was an interesting patient. This is my last video, where, see, where you can have difficulties while putting in the iris claw. So here I'm doing the same steps, put in the iris claw lens inside, pushing in viscoelastic, and I'm dialing it horizontally. But when I'm holding it, this was a forceps which was a little older one. So it was, the grip was not right. So look what happens. When I'm trying to enclave, suddenly the entire forceps tilts on itself. So the grip is not right. It's very important to have the right grip, a forceps which has a proper grip. So I changed the forceps and tried to enclave again, but see what happens again. And another thing is, I didn't have a third forceps. So now what I've changed is, look at the tip of the forceps. It's beyond the edge of the diameter of the lens. So here it gives a little better grip. So now I'm able to do it. Now on the right side, when I'm trying to do the same thing, I enclaved it, but I was not very sure. So you have to see the dimple very clearly. If the dimple is not clear, it means that the enclavation may not have occurred. So that means on the next day you might have one edge or both edges of the lens down. So here on the left side the dimple was seen, but the right side it was not seen very clearly. So I went in with the irrigation aspiration to see whether the lens goes down or not. Don't leave it for the next day, otherwise you will have a dislocation of the lens again. So we bring it up, enclave it again, and then you're fine. So this was the same patient next day post-op. So you can have certain complications like pupil ovalization, redislocation due to improper enclavation, raised IOP, endothelial cell loss, CME, and it's not an US FDA approval done for treatment of aphakia. So this was a literature overview, and advantages is as it's a simpler procedure, shorter learning curve, can be done by an anterior segment surgeon, no issues with the sizing of the IOL, and it centers well on the pupillary axis, and no damage to the angle or the iris root, can give good functional outcomes. Thank you so much.
That is really good.
Dispersive viscoelastic.
2-3 quick questions before Rohit takes over. What lens do you use? What forceps do you use?
So we have used 2 kinds of lenses. One is from the CARE group, and one is the XL lens.
So these
XL.
ones with that.
XL, yes.
These are XL. Okay. What forceps do you use?
So this
Whose
forceps was iris claw forceps. It has 2, one on top of the other. So it will hold it like this. But there are better forceps where you have a horizontal T kind of forceps. So that has a better grip.
Clayman forceps.
Yes. So that you can hold in the center of the lens, and it has a very good grip because it has a very broad central T.
So where do you get that forceps?
So you get it through Abhinandan.
नहीं एप्सिलॉन से मिल जाता है.
Epsilon also.
Clayman forceps.
Right. Thank you, Anagha. So there's a lot of questions we have to ask you on this. So let Rohit also
Yes.
have his talk, then we'll have a general discussion.
Yes.
Come join me here.